Good evening, and thank you for attending AACP's webinar with Dr. Scott Parker presenting Sleep, Snoring, and Airway Issues, Why Lasers Matter. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. The webinar is approximately 50 minutes in length, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. AACP's next complimentary webinar will be January 10th with Dr. Barry Glassman, presenting how to make evidence-based dentistry relevant, AHI and anterior midpoints in pain management and sleep. Also, AACP is proud to present the first package of the Pro Series Virtual Mini Residency Foundations. This course will grant you the knowledge required to assess and differentially diagnose the majority of craniofacial and orofacial pain and sleep-disordered breathing patients seen in dental practices today. Visit aacfp.org to learn more about this didactic, self-paced online course. I would like to introduce our moderator for tonight, Dr. Daniel Clower. Dr. Clower earned his Bachelor of Science degree at the University of Notre Dame. Upon graduating, he continued his education at Ohio State University, earning his Doctor of Dental Surgery. In 2013, Dr. Clower chose to limit his practice to treating patients with craniofacial pain, TMD, and sleep disorders due to the overwhelming need within the community. As he learned to identify the origin of patients' pain and sleep problems, it became increasingly clear that he could drastically impact their lives now and in the future. To that end, Dr. Clower has completed nearly 2 years of postgraduate training and over 1,500 hours of continuing education in craniofacial pain, TMD, and sleep medicine. He is board certified by the American Board of Dental Sleep Medicine, the American Board of Craniofacial Pain, the American Board of Craniofacial Dental Sleep Medicine. He is diplomate eligible with the American Board of Orofacial Pain. Today, Dr. Clower enjoys educating patients and giving them the tools to live healthier lives independent of medications and Band-Aid fixes. In his personal time, Dr. Clower spends as much time as possible with his wife and 5 children. He enjoys running, skiing, and finds pleasure in almost any outdoor activity. And with that, I'll hand it over to Dr. Clower.
Great. Thanks, Shay. Do need to update one part of that bio on the oral facial pain as that changed, as you all know. But I'm excited to have Dr. Parker here helping us out tonight. As we all know, there is so much to learn with lasers and the numerous different aspects of their utilization out there. And there's so many great lasers and some great partners and vendors in the industry. And many of us are very familiar and comfortable with certain lasers that we've been exposed to. But we wanted tonight to talk about, the kind of the actual nuts and bolts behind it and get like a second layer of understanding and be able to ask deeper questions. Many of you attended this year's annual meeting, and we heard a bunch of different lectures on lasers and what they mean. And so this is kind of on demand from members of diving deeper. So we'll have a couple of these throughout the year. But Dr. Parker is a real depth of knowledge, practicing clinician that has utilized every laser in his practice. And so he can talk the talk on many different facets of them. So he's been teaching and doing this since 1998. And he had just told me he'll hit about 500,000 miles this year and is doing well over 40 events a year, lecturing, across the country, doing trainings and stuff like that. So without further ado, I'll let Dr. Parker take over. And thank you so much for being here. We really, really appreciate it.
All right. So I'm just going to jump right in because I've got so much to cover tonight because there's a lot of misunderstanding about lasers. So I'm just going to go for it, and then hopefully we'll cover everything we need to cover and answer any questions at the end. And primarily, I want to focus on like why lasers with sleep or snoring or these types of issues, and why lasers help. And really, it comes down to a couple of different things. One is a lot of us are dealing with patients who have compromised sleep or compromised breathing or physiology, these different things that affect us daily. And they all have one thing in common, that's air or the lack of air as they're sleeping. We're not cleansing out our brains. We're not cleansing our bodies. We're not getting appropriate sleep. So how do we use lasers to manage these compromised patients? A lot of us are aware of the different wavelengths within dentistry. And primarily in dentistry, we only use 4 wavelengths. In medicine, there's all kinds of different spectrums of lasers that we can use, whether it's excimer, argon, KTP, dye, ruby, alexandrite. Those are all common lasers in the medical space. In dentistry, we can kind of boil it down to basically 4 wavelengths: diodes, and there's several different wavelengths of diodes, Nd:YAGs, erbium YAGs, and CO2s. And to me, erbium YAG, homium YAG basically do the similar thing, very similar in how they operate. So I just lump them together as erbium YAGs, but I understand there's a little bit of difference. Same with CO2s. There's a couple different wavelengths of CO2s out there as well. But the most important slide for us to understand if we're going to be using lasers in dentistry is what is the depth of penetration of our different wavelengths of lasers. And does it matter? And the answer is it absolutely matters, because different lasers will have different functions depending on, number one, their chromophore, what their target molecule is. For example, the two on the right in this slide, the diode and the Nd:YAG, they're looking for pigmented tissue. And they're really only looking for pigmentation, with the exception of, as we get into the 910 diodes and the Nd:YAGs, we maybe get a little bit of water in there as well, but certainly not nearly as much absorption by water as my erbium and my CO2, which are the second and the third from the left. But that absorption in the chromophore also affects how deeply they penetrate into tissue. So my diodes and my Nd:YAGs are going to penetrate deeply, as much as 4 millimeters into tissue. And my erbium, maybe 10 microns, 20 microns into tissue, CO2, maybe 100 to 200 microns into tissue. So very different absorption depths. And this matters when we're using these different lasers, because if I'm using a diode or an Nd:YAG on the soft palate to try and heat the soft palate, I could be damaging vessels 3 and 4 millimeters below the surface of the tissue, but I would never know it because we just can't see it. So we have to be really careful with the amount of heat we push into tissue, for that reason. Erbium and CO2, on the other hand, erbium is considered almost a cold pulse laser, because it's a very shallow penetration, and CO2 will get through the basement membrane with just one pulse of energy. So very different effects, very different outcomes, and we use them all for different reasons. Distribution of the energy when we're cutting on soft tissue, the radiation of heat away from where I'm working with contact lasers like diodes and Nd:YAGs is pretty significant, meaning my zone of thermal necrosis is going to be higher with a diode and an Nd:YAG than it would be with an erbium or a CO2. My coagulation with the CO2 will be superior to an erbium, but again, my erbium doesn't generate any heat, and that's why it won't coagulate very well, to a minimal extent anyways. One of the great innovations that came on our market when it came to lasers was pulsing our laser. This slide shows what happens if I'm trying to average, and the 2 over here means 2 watts of power. If I'm trying to average 2 watts of power to cut tissue with a continuous wave laser, the temperature in that tissue will continue to increase. This can lead to charring. Now, this doesn't matter if it's a CO2 or if it's a diode or an Nd:YAG. These lasers will continue to heat the tissue and create a charring layer as long as they're in a continuous mode. We came out with pulsing years and years ago And what we do is we make a higher power laser. In order to average my 2 watts here, the red dotted line, I turn my laser on and off, but I push it up to higher power. And you'll notice that the trend in the tissue is better. It's better than continuous wave lasers, but we still do see an increase, a net increase in the temperature of the tissue. We call that thermal relaxation time. Once we got into superpulsing, our thermal relaxation time is longer, meaning my tissue comes back to its original temperature before I put another burst of energy in there. But these lasers have to be much higher powered lasers with a shorter pulse duration. This is called superpulsing. So by doing this, what we see is we can cut in tissue without creating any thermal damage, meaning no charring of the surface of the tissue. If we look at what a beam profile looks like in these different lasers, diode lasers have a big, broad, flat top, which means if I cut with a diode, it's not going to be very precise because the cut width is going to be the same as the tip of the diode itself, and actually even a little bit wider because of the lateral thermal damage that we see with that. Erbium, same thing, very similar to a diode. We have to be careful when we're cleaving our fibers, whether we're using diodes or Nd:YAGs, because we can leave little sharp glass edges on those. So we want to be careful whether it's diode or Nd:YAG. Erbium, on the other hand, you notice this top doesn't have the heat in it. We call this a cold pulse laser because it's such a shallow penetrating laser. So therefore, we don't see the same coagulation or lateral thermal damage in erbiums that we do with CO2s, and much greater in diodes and Nd:YAGs. CO2 is still pretty minimal. The beam profile of a CO2 is very different. It's a Gaussian curve, which means that we can get this really fine point up here at the very tip where this is cutting, meaning right here, this cutting width of my beam can be as low as 125 microns. So we're cutting at the width of a thick human hair, but really uniquely, I can also pull a CO2 out of focus, which is harder to do with my other lasers. And instead of cutting into the tissue, I can just remove layers of tissue in a superficial way, which makes it really, really nice to be able to do all kinds of different applications. When it comes to focal depth, just by pulling back out of focus, I can actually ablate a wider swath of tissue without cutting deep into it. I actually am on the education committee for the Academy of Laser Dentistry. And I run across these challenges all the time where we get these conflicting messages about what lasers can and can't do. So I want to clear up just a couple things. This one was sent to me by a clinician. When it comes to Airway, CO2 methods are failing patients. And he said, I'm nervous about using a CO2 laser because if these are dangerous, then I don't want to use it. Well, this is absolutely just marketing. This is false. Or I should say misleading, because if you look at the fine print, it says here CO2 LAUP procedures. LAUP is laser-assisted uvulopalatal flap or uvuloplasty, meaning we're using a CO2 laser to cut off the uvula and cut away a big portion of the soft palate. Well, this is deceptive because that's not what we're using when we use fractional CO2 for our sleep patients. In fact, it's very safe to do. LAUP is a very invasive procedure, and I don't know of any dentists except for a handful of oral surgeons that have ever even done this procedure, and I do not recommend this for our patients. Extremely aggressive and very invasive, where we actually literally go in and we take out the back edge of the soft palate. This leads to swallowing incontinence because we've removed the back portion of the soft palate and part of the uvula. This is what it looks like surgically. Again, it's very, very invasive procedure. And the scarring that's created from this type of invasive surgery is very significant. I do not recommend this procedure for our patients. Again, this is not a comfortable procedure. So we have to be careful with that. I also have seen this slide many times where people will be presenting and say, you know, we don't use CO2 lasers because they generate charring. Well, this is actually very deceptive because if you notice in the fine print on this one, it says continuous wave 3 watts. Well, we don't use continuous wave CO2s to cut tissue. So this is not real. We would never in a million years use continuous wave with a CO2 to cut tissue. In fact, when we cut tissue with the CO2, we can cut 9 millimeters into the tissue with no charring, very little lateral thermal damage. So we have to be able to read between, as clinicians, read between the lines of who's trying to sell what. As far as the scar tissue, we actually can share all kinds of articles and research that's been done that says scar tissue is actually improved with CO2 lasers compared to using a scalpel even. And it's because of the slower healing. In fact, in the medical space, if we have scar tissue, the way we get rid of scar tissue is actually using fractional CO2 laser energy. So we minimize scarring by using fractional CO2 lasers. So not only are they safe and not only are they great for removing scar tissue, they're very, very non-invasive or minimally invasive compared to some of the more surgical procedures we can do for these big scar cases. This case was not done with facial plastics. This was a cancer on the nose that was removed. And simply by using a combination of lasers, this was a dye laser with fractional CO2, we're able to regenerate that tissue over time without doing a transplant or any type of dermal transplant. If we look at videos of people doing surgery using CO2 lasers, we can see very efficient cutting, no bleeding, and we see no charring in this case at all. So we have to be able to read through the hype. One of the questions that I get a lot of times is, when is the best time to do a tongue tie, a lip release or a tongue release? And the answer, I usually answer this with a question: when is the best time to plant a tree? And if we want to enjoy the shade of that tree, the answer is, well, 20 years ago. But we don't have that luxury. So we have to look at today. When is the next best time to do it? And the answer is now. And the reason I bring this up is because if we look at infants and we release a tethered tongue, and I mean truly tethered tongue, when they're an infant, we can avoid a whole range of problems for them down the road as they continue to grow. And I would much rather do a true tongue release on an infant than a 6-year-old, but I would still rather do a 6-year-old than a 25-year-old. And I would rather do a 25-year-old than a 45-year-old, because as we wait, we have all these other facets that begin to be a problem for our patients. And I'll show you a couple cases of an example of a 15-year-old. These are the cases we look for when I look at this infant and I say, is that a normal shaped tongue? And the answer is, it's not a normal shaped tongue, because that tongue cannot compress a nipple. And if that tongue cannot compress a nipple, this child cannot feed appropriately, and it leads to all kinds of development problems. Whether it's a narrowed mandible and a vaulted palate in the maxilla, a shortened face, we have all kinds of airway issues that develop because of these. And we can do these procedures quite easily. The problem with waiting, the problem is we develop an over large tongue, because to swallow from the base of the back of the tongue is not a normal function of the tongue. And there's a difference between a macroglossia and a megaloglossia. Macroglossia often refers to maybe our patients who have Down syndrome. They have an enlarged tongue. That's a normal condition that's usually due to genetics. But megaloglossia is usually an enlargement of the tongue due to overmuscularization. This is a perfect example. This is a 15-year-old already been through orthodontic treatment. If you look at the size of the cheeks, you'll see that this patient is a cheek chewer. They tried to push these teeth out to make more space, but because of the tongue tie here, which is a very severe tongue tie, this problem would never be solved. And unfortunately for this 15-year-old, it's too late. We released the tongue even at 15, but if you watch him trying to swallow, this tongue is not a normal functioning tongue. And it's huge in the back, which leads to other kinds of airway obstructions. And I can almost guarantee you that this poor 15-year-old, by the time he's 40 or 45, he's at severe risk of heart attack or a stroke because he's just not sleeping and breathing as he should be. So if we'd addressed this appropriately when he was an infant, we would have avoided a lot of these problems. When we do these procedures, there's a couple things that I like to tell people. One is we don't have to go in and just start cutting haphazardly under the tongue. We can actually use lasers to get access, and we can do blunt dissection with a cotton applicator. Now, my goal tonight isn't to teach you how to do a tongue tie, but just to show that there's different ways that we can do this. And it's not always one tool that solves the problem. It's a whole bunch of different tools that we use because as dentists, we run into all kinds of different problems. And again, just using our laser to gain access, in this second case, you'll see a pretty significant genioglossus muscle. After we get in here, we do our blunt dissection, you'll be able to see that just pop right out, which we don't always see if we don't get in and do a dissection like this. These two cases, the one on the left was my friend Cameron Fatah, who's just an absolutely fabulous surgeon, and the one on the right is one of the most gifted dentists I know. This is Lon McCrae. And both of these gentlemen are just fabulous operators, but you can see our structures now so clearly when we have the right tool. We do recommend, if you're going to be doing these at this type of a level, that we do suture under the tongue. We get a better result. We see less regeneration of these attachments when we can suture like this. So that's the surgical side. What's the non-surgical or the less invasive way to manage these airway compromised patients that doesn't deal with the tongue? Excuse me. If we look at how we've managed airway issues and snoring in the past, our non-surgical approaches may include recommending weight loss. I do recommend you add a question to your health questionnaire if you haven't already, which is, when was the last time you had your hormone levels tested? We don't have to be experts on hormones, but we should know the basics, and we should be able to have a conversation so that we stimulate that conversation, because it does matter. Walter Stumpf was one of the pioneers of doing vitamin D research on the actions of the brain and sleep. He was a very strong proponent that vitamin D isn't a vitamin. In fact, it's a hormone. And I think most of us are aware of that. Vitamin D and different combinations of these things can be profoundly impactful for our patients who are having issues. We recommend patients avoid alcohol before going to bed, or caffeine, same thing. If a patient says, well, I can drink a cup of caffeine and go straight to bed, it doesn't mean that you can't go to bed after a cup of coffee. It means your body isn't getting the regeneration it needs. And that comes from different levels of sleep, not just being asleep. So we have these different cycles of sleep that are very important, and all three different stages of sleep are very important for different aspects of our recovery of our physical system, but also our brain system as well. We recommend decongestants, maybe a positional sleep appliance or a pillow or a bed that sits up. As dentists, we do a lot of oral appliances. In medicine, the standard of care is CPAP. We're now adding lasers into this therapy. Of the surgical approaches that we use for our sleep patients, maybe a nasal surgery to open up their nasal passages, maybe a laser-assisted uvuloplasty, maybe a triple P or a U triple P or a pillar procedure, which we use a stiffening rod basically in the soft palate to change the vibration frequency of the soft palate. All of these different things. Of the two on here that have been mostly successful, or I'd say more successful than the other ones, probably our MMA and our nasal surgery are the two most successful on this list. The other ones often end up, as I mentioned, with soft palate incontinence, which means regurgitation of the food when our patients swallow, because the soft palate no longer seals, seals against the back of the throat. So we got to be careful with that. In order to understand how laser soft palate treatments go for our sleep patients, we got to kind of understand the basics of lasers in general. And right now, I'm just going to talk really quickly about what we used to do and think of just pure facial aesthetics. What does it mean from a facial aesthetic standpoint? When we first started doing facial aesthetics, we did what's called ablative resurfacing, where we use a laser and we literally peel off the whole outer layer of skin. Very dramatic, meaning we get dramatic results, but we also look dramatic during our healing time. Single treatment, very effective long-term results, but because we walk around looking like a burn victim, we're at severe risk of infection and other complications. Now, when you look at this slide, I know it's kind of gross, but this isn't a bad result. This is what it looks like when we're healing. And so we have to be very, very careful. We can't be in the sun. We have to kind of hermit away for 6 weeks. We have to kind of just stay out of, basically, we have to hole ourselves away. But our society doesn't tolerate this very well. However, the results are dramatic. Okay, we can see just incredible results when we do it. But most people don't have the patience to go through this today because 6 weeks is a long time and it's a lot of downtime. We also use non-ablative resurfacing, meaning we don't do anything to alter the outer surface of the skin. All we do is we heat up the collagen layer. Because we're not altering the outer surface, we don't really have that much of a side effect other than the discomfort during treatment. Usually requires a series of treatments, and the results are short-lasting because we're only stimulating collagen. But here's the kicker. In order to stimulate collagen correctly, we have to stimulate the collagen up to a temperature that affects the heat shock proteins. And that temperature is going to be about 140, 150 degrees Fahrenheit. For any of you that have ever jumped in a 140-degree hot tub, you'll know that's very hot. And I'm kidding, because we would never jump in a 140-degree hot tub. We would actually denature the protein. We could do some serious skin damage and eventually other damage too. And the example I give for this is if you're eating hot cheese pizza and you leave it on the roof of your mouth and you melt the roof of your mouth, that's the temperature we're talking about. It's uncomfortable, and the effects can be pretty significant if we're not careful with it. However, used correctly, we can get some pretty good results. If you look at this before and after, there's definitely a change here. Not nearly as dramatic as the other case that I just showed, but you can tell there's a difference. But it needs to be retreated about every 18 months because that collagen will go back to its original state without continued stimulation. The third option today, and I'm going to tie this into how we use it as dentists here in just a minute, is called fractional ablation, meaning we take a beam of laser light down, we actually hit this pixel beam splitter, and we split this laser beam into a whole bunch of little tiny pinpoint beams of light, and we reflect that down into the skin. We call this the Holy Grail because we can change how closely all those dots are, or how far apart they are, and how deeply they penetrate into the tissue. So fractional ablation is nice because we can still see very dramatic results using fractional ablation. But instead of removing a layer of skin or tissue, we actually make vertical punctures down into it. So we get the tightening as this little tiny dot wound closes, and that's the tightening effect. But we also get this stimulation of the collagen down in these deeper layers, which leads to the overall improvement of the tone of the tissue. So it's kind of a twofold approach to doing this. And those little tiny thermal wounds that we create are what are really essential for stimulating that collagen. If we imagine now as dentists treating the soft palate with this whole grid of dots that go down into the mucosal tissue, now not the dermis, each one of these little vertical channels of light and energy goes down, and we make a puncture. But down below that layer in the lamina propria, that heat, when it gets up to the right temperature, stimulates our fibrocytes. Our fibrocytes are shocked into becoming fibroblasts, which then release all their little magic molecules, one of which is high hyaluronic acid. And for everybody listening, I'm sure you've heard of high hyaluronic acid. It's what we use to stimulate new collagen attachments, and also remodeled and improved tone of collagen. So imagine doing this on the soft palate of an older patient. We actually improve the tone of the soft palate. So we dramatically reduce snoring, but also improve the tone of the soft palate, which leads to better airway. And again, it comes back to depth of penetration. And we have to understand this because in order to stimulate the lamina propria, where our collagen cells reside, we have to be able to get down into this layer. So if I'm using a superficially penetrating laser, I can't do that. I have to use a combination of lasers or the right wavelength. There's two different types of lasers that are being used to do this right now. One is a combination of lasers, which uses a combination of an erbium YAG with an ND YAG. The ND YAG is used to stimulate the collagen down in the lamina propria, and the erbium is used to do the superficial ablation. And the CO2 will do the same thing, but just with one pass across. So its native depth of penetration is going to be superior, which means I can stimulate with a CO2 lamina propria in addition to getting my superficial puncture up here as well. That superficial puncture is important, by the way. There's some companies now that are doing this type of a technique, but they're doing it non-ablative. Those results won't ever come close to a true fractional ablative laser or a combination of lasers. So there's 4 different lasers on the market right now that are doing this. One of them is an erbium YAG, ND YAG. This procedure, if done correctly, takes about 40 minutes, maybe 35 if you're good. The fractional ablative CO2 takes about 4 or 5 minutes. The non-ablative fractional CO2 is just a little bit over 5 minutes. So we say between 5 and 8. But again, you're not going to get that, that little ablative channel up in the top, which leads to the initial tightening of the tissue. So those are just the different options that are out there. The reason that this is important is this little channel that's created that goes down into the tissue, the body heals that by tightening across that gap by primary intention. This is super important that we as clinicians understand this, because there's different widths of channels based on the wavelength of laser we're using. A properly executed channel will be about 125 microns in width, which is enough of a width to create a tightening, but not enough to create a fibrin cover, which can lead to scar tissue. So when we're doing punctures of 125 microns, we can rest assured that we are not developing scar tissue in the surface of the tissue. Please understand, if you didn't hear that, you got to understand that. As long as my puncture with a CO2 laser, which a typical CO2 fractional ablative laser will be about 125 microns across, we do not generate the risk of developing scar tissue when we use fractional CO2 on the soft palate. There's a lot of misunderstanding about this out there. So please understand, with CO2 fractional, you will not see that. Now, with an erbium, we have to be careful, because an erbium is going to be the same diameter as the fiber that's being used to do this, but in a fractional ablative mode, we see erbiums can be anywhere from 150 up to 350, sometimes 400 microns wide. The magic width of this hole for developing a fibrin cover, which is secondary intention healing, which can lead to scar tissue, that magic number is right around the 350 micron range. So any hole that's greater than 340, 350 microns, we do run a risk of scar tissue formation by using these lasers. As clinicians, it's essential that we understand that. And we know those numbers so that we can avoid any risk of scar tissue to our patients. So what happens when we do these treatments in a fractional ablative manner? Number one is we create this little micro puncture in the surface of the skin. The body heals that by primary intention. So by day 2, it's pulled that wound back together through primary intention. And we actually get an initial tightening or shrinkage of that tissue. So when done fractionally ablative, patients noticed almost immediately that there's something different. Some of them will say, when I speak, I can actually hear the difference in the tone of my voice. I feel like I'm breathing better. We get these comments all the time. But that heat shock that's happening down here in the lamina propria layer, we've converted here at day 1, we've stimulated those fibrocytes to become fibroblasts. By about day 3 or 4, those fibroblasts are now starting to wake up. By day 7, they start making this new collagen. And you'll see this new collagen response ramp up here at about day 21 to 28. This is a magic time for us because this is when these cells are the most active. The fibroblasts are really cranking out new collagen. That's a beautiful time to hit them again with the laser because we're going to stimulate those cells, those active cells, even more. So perfect window for retreatment is 21 to 28 days. And we continue to see this remodeling that's happening there in the lamina propria for as much as 18 months, but we recommend that we get them back before that. This is not new technology. This has been going on for a long time. There's been research on here that's been happening for as much as 20 years as far as using fractional ablation on mucosal tissue. Again, not new stuff. We've been doing research on this for 20 years. Histologically, this is what it looks like immediate post-op. This is 2 days later. You can see this is already starting to bridge over. 7 days, we're starting to really wake up these cells. They're waking up. A month later, you can see just this beautiful collagen response here. 3 months later, still going strong. So really, really great to be able to see this. So these are durable results. That deeper penetration into tissue means better collagen stimulation. And again, this superficial fractional ablation, and again, fractional ablation is really, really important for us, leads to more immediate relief. And again, guys, I'm sorry I'm going rapid fire because there's just so much content I want to share. Where do we treat? We treat all of the soft palate. So anything that's soft palate based, we treat the crypts where the tonsils reside. We can just stamp right across this with our laser, with this fractional ablative. We treat the uvula. We treat the tail edge of the soft palate. We want to get that tissue as tight as we can. And again, we're not surgically removing any tissue. We're just doing superficial fractional ablation. We also recommend treating the lateral border of the tongue, but only the back part of it, because there is tonsillar material on the side of the tongue that's often inflamed. We can get that to calm down by using laser energy. So we can calm down some of the inflammation we see, but we don't come any further forward than halfway because we can alter their taste. In dental school, we were taught about the lingual tonsils. Most of us forgot about the lingual tonsils, but if you notice these 2 little domes, kind of this swollen shape here in the back of the tongue, those are swollen lingual tonsils. If we can get those to shrink up, we have more airway. So more air volume can go across there. So we do also treat the posterior dorsum of the tongue, the lingual tonsils. Very important. And just to remind us, we not only have the palatine tonsils, which all of us see, but we also have the lingual tonsils, and these do wrap around the side of the tongue as well. Is it painful to treat these things? Well, let me show you a video of this is a 7-year-old. Oh, buddy, you're doing awesome. Can you say "aw" and for me? Imagine how this little guy is trying to breathe. There's no airway here. These are very low settings, and we call this a decontamination setting. Again, treating tonsils for us as dentists is an off-label use. As a clinician, you're welcome to do off-label uses, but companies have to be careful whether they tell you or not to. But you can see the look on this little guy's face that he is not numb for this procedure. It's very comfortable, very, very well tolerated, not scary, not dangerous. We can rest assured. This is immediately after just one pass.
I can already see more airway
with the laser, and you can already see a dilation of that airway.
Difference already.
So with multiple passes, you can really calm that tissue down. This is what it looks like on an adult. So you can kind of see what treating a tonsil looks like after. Again, laser companies should tell you this is an off-label use. As clinicians, we are able to do this, but To be super clear, we are not promoting using lasers to do tonsillar removal. So tonsillectomy is off the books for us. Tonsillotomy is off the books for us. This is just decontamination of the surface. And you can see by looking at that, we did not remove any tonsillar tissue. We're only decontaminating the surface. Once we've decontaminated the surface of the tonsil, these germinal centers, which are creating all this lymphoid tissue, these start to shut down because this factory is no longer needed once we've decontaminated the surface. And you'll see this shrink often even overnight. This is literally 1 day after treatment. So very, very effective for doing this. Studies on this were done out of Brazil. This is tonsillotomy. Again, as dentists, this is out of our zone. These were extremely high settings, but the results were no complications. Procedure was fast, safe, and tolerated well without general anesthesia. After 1 year, there was a total remission of recurrent acute tonsillitis in 95% of patients. So very significant. This is what it looks like when we treat the soft palate. You'll see these little white dots forming on the soft palate. Each one of those is a little tiny vertical channel down into the soft palate, which again, we're stimulating the collagen down in that lamina propria when we go across. Now, I personally have recommended going across the soft palate because then you'll see the, if they're like a Malampatia 4, you'll start to see that that back edge of the soft palate creep up. But I have other clinicians that like to go in a vertical fashion. This is what it looks like when you're doing it in a vertical fashion. You'll notice how quick this is. None of these patients are numb. We do not even have to use a rinse for this because that flash of laser energy happens in about 400 microseconds, which isn't enough time for our patients even to perceive the pain. This is what it looks like when we treat the sides of the tongue. Again, just in the back of the tongue, we do not need to come forward. And you can see those dots happening to try and shrink up some of that swelling that we often see on the sides of the tongue. And that swelling is also part of the problem from suction, clenching, and grinding. We can use it to treat linea alba, lichen planus. We can easily treat the cheeks with this. We can be a little more aggressive if we have a linea alba and we're trying to erase some of that tissue, that swollen tissue from clenching on the cheek. And we can even use a 90-degree handpiece on the back dorsum of the tongue to try and shrink up those tonsils. This is a 90-degree handpiece being applied to the back of the tongue. Obvious challenge with doing this on the tongue is the gag reflex, very common. But what I've seen is after 2 or 3 treatments, this gag reflex goes down dramatically. We kind of desensitize the area, and often these patients that are profound gaggers start to become less gaggy. There are things on the market that we can buy to help if they have a strong gag reflex. Diclonine 1% is commonly used for people who have a gag reflex, and it does have a superficial numbing as well. Some people like to use acupuncture. Some people like to use photobiomodulation to stimulate acupuncture. This is using a endodontic file in an acupuncture point to reduce the gag. Based on time, I'm going to just get to the point where we naturally said this. We could not do that even just 3 minutes earlier. If we look at the soft palate, you'll see that there's an inflammatory response that's necessary to stimulate the collagen and very well tolerated. But it's all just anecdotal if we don't have results. So how do we measure results? There's lots of snoring applications out there to monitor our patients' snoring. These are 3 different patients. We had an 18% reduction after just 1 treatment. Here's a 68% reduction after just 1 treatment. Here's a 58% reduction after just 1 treatment. Here's a doctor who sent me his studies. He had a 92% reduction after just 1 treatment. When we look at AHI, we see a general 30 to 50% reduction in AHI after just 1 treatment. It does not mean we don't recommend oral appliance. It means we have 1 more tool in our tool belt. For those of you who do sleep studies, these are various sleep studies. We took an AHI from a 25 down to a 14 with just laser, no appliance. And then we deliver an appliance and we titrate in. These are all now just treatments with lasers. One was AHI of 37 down to a 20 after 3 treatments. AHI of 29 down to a 19 after 3 treatments. Here's a 25 to a 12 after 3 treatments, and a 29 down to a 3 after 3 treatments. We also measure with a pharyngometer. This measures the oral air volume and the airflow. Rhinomanometers measure nasal airflow, so oral versus nasal. The tighter the curve, the more restricted the airflow. The more open the curve, the better the nasal airflow. So this is a doubling of the nasal airflow volume. Here's a tripling of the nasal airflow volume. Now, remember, we did not treat the nasal passages. This is just treating the soft palate, but because there's 2 sides to the soft palate, once the inflammation is reduced, nasal airflow is much, much, much easier. If you ever see a Mallampati result like this, don't ever believe this. This is an inaccurate Mallampati. This is a contracture of the soft palate, and you can tell because the uvula is completely retracted up into the soft palate. So this is not a Mallampati. This is a more accurate Mallampati view, where the before and after the uvula looks exactly the same, but you can see an increase in airflow. Again, it all comes down to airflow and oxygen. We have to get more oxygen to our patients. Last topic I want to review, and then we're going to open it up to questions because I'm watching our time. And that's oxygen and how we can get more oxygen. Dr. Clower and I were talking before this and about the importance of using infrared and red light therapy to stimulate things like cytochrome C oxidase, which we know leads to better ATP production, which leads to nitric oxide production. We know how important nitric oxide is in the regulation of our bodies. But what we found is even using some of these lasers to the forehead benefited cognition in healthy humans, including enhanced attention, working memory, executive functions. And it comes down to using different wavelengths of light to stimulate the body. There's lots of different wavelengths we can use, but some penetrate deeper than others. An Nd:YAG will penetrate deeper than a 910 diode, or a 980 diode, which will penetrate deeper than an 810, which will penetrate deeper than a 640 or a 500 or a 400 nanometer laser. So they're all important, but the longer the wavelength, the deeper the penetration, because there's less absorption by our chromophores. So different lasers do matter for stimulating the mitochondria of the cell. We've known for years that we can use lasers to stimulate the mitochondria and the cytochrome C oxidase. And that leads to greater ATP production, or ATP production and utilization. But there's a thing that's very uncommonly talked about, and that's the byproduct of stimulating cytochrome C oxidase, which one of the byproducts is nitric oxide. Breathing through our nose stimulates more nitric oxide, as do using these types of lasers. We know that nitric oxide plays a very important role in the protection against the onset of not only cardiovascular diseases, but also mental diseases, things like Alzheimer's, because it's also crucial for maintaining our synaptic plasticity. So these different things are very important. It can help against insulin resistance. We call that heart disease. And these things are all very much associated with a decrease in nitric oxide bioavailability. So very important for us to understand these types of pathways. What are the contraindications for using, say, fractional lasers on the soft palate? Well, we would not ever use these on our patients with connective tissue disorders. So Ehlers-Danlos, Marfan's, osteogenesis imperfecta. We want to be very careful. In fact, we recommend you don't use them on patients with a history of keloid formation. It's not truly contraindicated during pregnancy, but we would want to be careful with it. For our COPD patients, obviously we're going to turn off the oxygen, but there's a whole nother discussion around that. Photosensitive medications, I'm not as worried about that on mucosal tissue, but they will have a different heat reaction to lasers than, say, patients that weren't on photosensitive medications. I'm talking about things like Accutane. And then also, we got to remember that our kids, we're not doing this to stimulate collagen. So we would use it more to just dilate the oropharynx and maybe to decontaminate a tonsillar surface, but not so much for collagen stimulation. So I've talked 100 miles an hour, and I want to have some time now to answer questions, because I went through a whole lot of different information on there. So perhaps, Shay, we can open this up for some Q&A, and Daniel. And
we got some questions, and I'll feed them to you, and we'll maybe do rapid fire here.
Awesome. Love it. Thank you.
Can this treatment be done in combination with PRP to help healing?
Oh, wonderful, wonderful question. The answer to that one is absolutely yes, it can. There are people that are doing this, and the studies are showing an even greater efficacy when used in combination with PRP. So excellent question. We commonly, on facial aesthetics, we will do all the little punctures, and we can apply PRP or other types of materials to the surface of the skin for different effects. Yes, absolutely. Brilliant question.
And we've been using that with some facials, and the results are awesome, doing the combination of it. Can you treat the nasal passage, and some commentary on that?
Yeah, so this is actually an interesting question. We can treat the nasal passage, and there are adapters that are made to specifically do this, and especially targeting, say, the nasal valve. But the question I always ask, which is maybe a different question, is it necessary? Because if we go back to those slides that I showed earlier using rhinomanometer studies, we see a 100%, on average, a 100% increase in nasal airflow volume when we only treat the soft palate. And usually that's adequate for most patients. We are working on adapters to use fractional CO2 into the nasal passages. I would recommend being very careful with this. So the quick answer is yes, you can do that. There are some that are available, and there are some that are being researched and prototyped even as we speak. But we also are getting phenomenal results even without treating the nasal passage. And to that point, we used to treat the floor of the mouth as well. More and more, we're getting away from treating the floor of the mouth because we saw no real benefit or improvement of results when treating the floor of the mouth, but only risk. And it's not high risk, but for us, it's time and it's some risk, but really not much of an improvement in the results. So we found that it wasn't really necessary to treat the floor of the mouth either. So kind of the same answer maybe to treating the nasal passage.
Great. And how do you determine who's a good candidate preoperatively? What are you kind of looking for to vet out that you're going to take the case on?
I would never recommend anybody do this type of treatment without a sleep study. I do have a lot of people that say, well, I want to do snoring and I only want to treat snoring, so I don't need a sleep study. My answer is, actually you do, because the last thing you want to do is find out that your snoring patient also had a sleep disorder and maybe something happened and they passed away. Heaven forbid a patient were to pass away during treatment. Well, that would kind of be our fault, or at least that would be the perception. So in order to proceed, we always recommend a sleep study. We do a Mallampati view. We look at the length of the soft palate. We look at tonsils. We look at whether they're a mouth breather, a nasal breather, are they clencher, are they grinder? There's so many things that we need to look at. And we have to look at the overall picture in order to determine which of our patients are going to get a better result. If I do a snore study and their snore score is 185, I know it's going to take me longer to get results on that patient than a patient who maybe starts with a snore score of 80. So each of those is a little factor in treatment. The good news is treating fractionally ablative is a very safe procedure to do. And technically, it's even a reversible procedure, because if you don't like the results, wait 18 months and it's going to revert back to where it was anyways. So it's not permanent like a surgery, which is actually good for us as dentists because it means it's very, very low or very non-invasive.
Do you have any research or aware of any on biolays, eye water lays for these type of treatments, and how is that working?
Yeah, I don't personally have any research for them, but I would ask them if they can provide it for you. I know that they are using this in other countries. BioLace is using this in other countries with some success. And I know they just came out with a new attachment for facial aesthetics. I think the result, I can't answer from a results perspective because I've never seen any results from their studies.
What type of laser is that?
Well, it's erbium chromium YSGG is, I believe, what they're using for that wavelength. So basically an erbium YAG style laser.
Okay. And is LLT with diode recommended for faster healing? And I'm not sure if that means after you do the CO2 procedure, or but I assume that's the context in which.
Yeah, so LLLT is an abbreviation, an acronym, stands for low-level laser therapy. When I first started, we called it cold laser therapy. Today, we call it PBM, photobiomodulation. It's all a simple way of saying using laser energy to stimulate biology. So LLLT is not exclusive to diode lasers. LLLT can be done with a wide variety of lasers, low-level laser therapy. Now, the reason we call them low-level lasers is because they're considered class 3A or 3B lasers, which means they're generally safe for use in most applications. And the amount of heat that they push into the tissue is very minimal. 3B does generate a little bit of heat, 3A no heat in the tissue. And so they will stimulate the mitochondrial process to heal, but they're not going to stimulate like a low-level laser, like a diode laser is not going to be as effective as, say, using a ND-YAG that's a high-power laser. The problem is high-power lasers are class 4 lasers, so you have to be more careful with them because you can push heat in the tissue, but you will get a more profound biologic response from an ND-YAG that's superpulsed, or even a superpulsed high-powered diode laser, than you will with a low-power diode laser. And then there's another level that's even above that that's called high-intensity laser therapy. That can only be done with a superpulsed ND-YAG. And there's only 2 of them on the market. I won't name their companies, but there's only 2 on the market. One is a much faster pulsed laser than the other, but those are the only ones that can do true bone and cartilage stimulation, which the other lasers cannot do. So low-level lasers, high-power lasers, high-intensity lasers. There are 3 different categories of lasers that we can use in dentistry, and each one will build on the other. So can you use that after, say, an extraction or a surgical procedure to stimulate better healing? The answer is yes, you can with all of those. Long answer.
Yeah. And last question, and then we'll call it a night. How are you differentiating between soft palate and base of tongue obstruction? And I imagine that's, prior to doing a procedure, what you're going to target.
Yeah, this is an excellent question. And the answer is I don't differentiate between those two. They're 2 distinct modalities. Soft palate, if I have a patient comes in with a Malampati of 4 and they have a 45 millimeter soft palate, that's a very different scenario from a patient comes in with a Malampati of 3 with a 30 millimeter soft palate. Very, very different scenarios between the two. So one is a very long soft palate, one's very short, but both of them, to be clear, can have an airway or an air obstruction. And so we would come at those a little bit differently just based on the soft palate. The base of the tongue, the way we measure that is I have them stick their tongue out, and we evaluate their tongue to see if there's any swelling, if there's any, if there's one side that's more swollen than the other, if I see tonsillar swelling, if I see swelling on the sides of the tongue, or if I see any form of macroglossia or scalloping or even a linea alba, then that's a tongue issue as well. And what I found in my Mallampati 4 cases is often the Mallampati 4 comes along with the tongue suction that's happening. So there's scalloping on the tongue. There's usually a linea alba. It's all kind of a combination. I usually see there's a grinding event that's happening with them too, not clenching, but grinding, where their body's trying to find a way to capture more air somehow by getting rid of the teeth. So very distinct between those two.
Well, thank you so much, Scott. This was awesome. It's clear you got a wealth of knowledge, and we appreciate you sharing it with us and your expertise. For members, any additional questions, feel free to shoot over. I'd be happy to compile them and maybe lean on Scott to give a quick Q&A if there's some short answers that he can spot check for you.
Happy to.
So thank you for giving your time and energy to the Academy. We really, really appreciate it. And thank you everybody for attending. Shay and your team, thanks for helping organize this. And you guys will get the recording in 10 to 14 days. And hope everyone has a wonderful holiday and a happy new year.
Absolutely.
Thank you,
Thank
everyone.
you.
All right. Thanks, Scott. Have a great night.
Thanks all.